Hi, my name is Farah Shah, and I'm a second-year internal medicine resident at Harbor-UCLA Medical Center. I'm presenting a devastating case of spontaneous intracranial hemorrhage in a patient with immune thrombocytopenic purpura, or ITP. ITP is an acquired thrombocytopenia caused by autoantibodies against platelet antigens. Bleeding may occur in up to two-thirds of patients and typically manifests as petechia, purpura, and epistaxis. Severe or critical bleeding, such as intracranial hemorrhage, is less common and only occurs in about 1.4% of adults. This is a 59-year-old male with a past medical history of primary chronic ITP who presented with a 3-day complaint of hematochezia. He had multiple prior admissions for the same complaint. In the past, secondary causes of ITP were ruled out. His bone marrow biopsy and aspirate were significant for mutations related to myelodysplastic syndromes, or MDS, but did not fulfill morphologic criteria, as seen in Figure 2. Prior endoscopy, push enteroscopy, and colonoscopy identified no source of bleed. This admission, his vitals were stable. He had multiple 2-centimeter violaceous lesions to his tongue on physical exam. Bright red blood was also noted on digital rectal exam. He had no focal neurological deficits. Diagnostics were notable for anemia, thrombocytopenia to less than 5,000 per cubic millimeter, normal white blood cell count, and elevated BUN and creatinine. His CT had shown no acute abnormality, as seen in Figure 3A. He was given packed red blood cells, platelets, and IVIG. On hospital day 2, he had 3 maroon-colored bowel movements. His platelet count remained less than 5,000 per cubic millimeter. Packed red blood cells and IVIG were given again. On hospital day 3, a code stroke was called for slurred speech and altered mentation. His NIH stroke scale score was 26. CT head without contrast, as seen in Figure 3B, showed a large area of left cerebral hemorrhage with an 8 mm rightward shift and mild contralateral non-communicating type hydrocephalus. The patient was upgraded to the ICU after intubation and pressor initiation. Notably, his platelet count was still less than 5,000 per cubic millimeter. Platelets, packed red blood cells, and cryoprecipitate transfusions were initiated. He was also given IV DDAVP. His family arrived and elected to compassionately extubate given poor prognosis. Figure 1 shows the patient's average platelet count from time of ITP diagnosis to time of death, with a table of treatments received during this time period on the right, including glucocorticoids, IVIG, and Rituxan. Notably, as glucocorticoid treatment was tapered off month 10, the patient's platelet count severely decreased. Figure 2 shows a peripheral blood smear on the left demonstrating marked normochromic normocytic anemia and notably marked thrombocytopenia. Bone marrow aspirate on the right shows trilineage hematopoiesis and is also significant for adequate megakaryocyte number and no dysplastic megakaryocytes. He does not have increased blasts. This case demonstrates a patient with multi-refractory ITP and possibly a component of MDS who suffered the rare but devastating consequence of intracranial hemorrhage from his disease process. His bone marrow biopsy revealed MDS-related mutations, including SRSF2 and TET2 mutations. SRSF2 mutations are not significantly associated with thrombocytopenia. However, TET2 mutations have been associated with decreased platelet count and platelet dysfunction. Both SRSF2 and TET2 mutations are associated with high-risk MDS. Predictors of severe bleeding at ITP include platelet count less than 10 to 20 million per liter, previous minor bleeding, and advanced age. For emergency management of severe bleeding, high-dose corticosteroids with IVIG and platelet transfusions are recommended. Emergent splenectomy can be considered for severe refractory thrombocytopenia and life-threatening bleeding. Of these, IVIG has the fastest onset of action at 24 to 48 hours. So, what is notable about MDS-associated ITP, and how is it treated? Well, in one study, MDS-associated ITP patients had a higher chance of multi-refractory disease and severe bleeding when compared to primary ITP patients, despite similar platelet counts at diagnosis. Additionally, response achievement with IVIG was more frequent in primary ITP than MDS-associated ITP. Notably, there was no difference in response rates between the two groups to second-line therapies. Why is this case important, and what are the major takeaways from it? Well, this case demonstrates that ITP with persistently low platelet counts carries a grave prognosis. It also highlights that further research is needed to help identify strong treatment strategies in primary and MDS-associated ITP that can help prevent severe bleeding. Lastly, it shows that an aggressive and active therapeutic approach should be pursued in the management of patients with multi-refractory ITP. Thank you.